Assalamu alaikum. I am Dr. Mahbubur Rahman Polash, Assistant Professor, Department of Pharmacology at Bashundhara Ad-din Medical College. Welcome everyone in our today's session. Today we will discuss about non-steroidal anti-inflammatory drug or NSAID drugs. NSAID is the drug that is used in pain and inflammation, that is infrequently used in our day-to-day life. So, a fair knowledge about NSAID is necessary. So, let us go start. Principal actions of NSAID, three principal actions: analgesic effect, anti-inflammatory effect and antipyretic effect. Now, come to the classifications of NSAID. According to selectivity, it can divide it into two broad headlines: non-selective COX inhibitor and selective COX-2 inhibitor. Non-selective COX inhibitor, it inhibits both COX-1 and COX-2 pathway, and selective COX-2 inhibitor that only blocks COX-2 pathway. In non-selective COX inhibitor, the drugs are paracetamol, aspirin, indomethacin, diclofenac, aceclofenac, ketorolac, mefenamic acid, sulindac, ibuprofen, naproxen and ketoprofen. And in selective COX-2 inhibitors, drugs are celecoxib, etoricoxib and rofecoxib. According to efficacy or degree of anti-inflammatory effect, the classification can be divided into three ways: weak efficacious, mild to moderate efficacious and strong efficacious NSAID. In weak efficacious NSAID, paracetamol, and mild to moderate efficacious NSAIDs are ibuprofen, naproxen, ketoprofen and mefenamic acid. Strong NSAID includes aspirin, indomethacin, diclofenac, aceclofenac and ketorolac. This is a picture where arachidonic acid synthesized from cell membrane phospholipid through phospholipase A2 enzyme, and from arachidonic acid through cyclooxygenase pathway prostaglandin, thromboxane and prostacyclin are synthesized, and through lipoxane pathway leukotrienes are synthesized. Prostaglandin, thromboxane and prostacyclin are responsible for inflammation, and in prostaglandin it is also responsible for fever, vasodilation and chemotaxis. Thromboxane that increases platelet aggregation, and in prostacyclin it decreases platelet aggregation. NSAIDs that are commonly used are diclofenac, ketorolac, ibuprofen, etoricoxib and aceclofenac. Now come to the aspirin. Aspirin source extract of bark of willow tree. Acidic drug well absorbed from stomach, and pharmacological effect of aspirins are its an analgesic effect, anti-inflammatory effect, antipyretic effect and antiplatelet effect. When we will get analgesic or anti-inflammatory effect, if we give greater than 300 milligram, then we will get analgesic effect or anti-inflammatory effect, and antiplatelet effect can be achieved when it is given 75 to 150 milligram. Now come to the antiplatelet action of low dose aspirin. Low dose aspirin, it inactivates cyclooxygenase or COX irreversibly. The platelets are unable to synthesize new enzyme. COX activity is lost for the platelet lifetime 8 to 10 days. Prevention of formation both thromboxane A2 and prostacyclin. Thromboxane A2 causes platelet aggregation, but prostacyclin inhibits platelet aggregation. Low dose aspirin abolishes synthesis of thromboxane A2 without significant impairment of prostacyclin formation, and as a result antiplatelet effect can be achieved. Now come to the analgesic effect of aspirin or NSAIDs, and mechanisms are: irreversibly inhibits cyclooxygenase enzyme, then inhibition of prostaglandin synthesis. Number 2, it blocks the pain sensitizing mechanism induced by bradykinin, tumor necrosis factor alpha and interleukins. Then aspirin also inhibit pain stimuli at stimuli at subcortical site and rising threshold to pain perceptions. As a result, we get anti-inflammatory effect, analgesic effect and antipyretic effect. Indications in cardiovascular system, aspirin is given in coronary artery disease, unstable angina, deep vein thrombosis and prosthetic heart valve. And in cerebrovascular disease, it is given in transient ischemic attack. It also given in mild to moderate pain like rheumatoid arthritis, headache and dysmenorrhea, and in acute rheumatic fever. Adverse effect of aspirin, GIT effects, nausea and vomiting, gastric irritation, dyspepsia, ulceration, perforation, hemorrhage, hematemesis and melena. Now come to the paracetamol or acetaminophen, has antipyretic effect, weak analgesic and lacks anti-inflammatory and antiplatelet effect. It is a safe drug and oral dose 0.5 gram to 1 gram every 4 to 6 hours with maximum daily dose 4 gram. Mechanism of action of paracetamol, reversibly inhibits cyclooxygenase enzyme, inhibition of prostaglandin synthesis, inhibit the action of endogenous pyrogens on the heat regulation centers in the brain. As a result, antipyretic effect is achieved. Indications of paracetamol, fever, mild to moderate pain like headache and musculoskeletal pain, and patient with hemophilia and dengue. Now come to the adverse effect are common for all NSAIDs. GIT effects include epigastric pain, nausea, vomiting, gastric irritation, peptic ulcer perforation, and CNS effects include headache, tinnitus, dizziness, CVS effects hypertension, edema, hepatic abnormal liver functions, hepatotoxicity in overdose, renal effects, chronic renal disease or analgesic nephropathy due to long term use of NSAIDs, and pulmonary effects are bronchoconstrictions. Acute paracetamol toxicity, it happens when 12 gram at a time is fatal, severe hepatocellular damage and renal tubular necrosis occurs, and antidote of paracetamol is N-acetylcysteine. Ibuprofen, mechanism of action, reversibly inhibits cyclooxygenase enzyme and inhibition of prostaglandin synthesis, decreased level of bradykinin, histamine, interleukin, tumor necrosis factor alpha and other chemical mediators at the site of inflammation, no stimulation of A, delta and C fiber, no transmission of pain, and as a result relief of pain occurs. Indications, rheumatoid arthritis and osteoarthritis, post-operative pain, musculoskeletal pain and dysmenorrhea. Adverse effects are that has previously discussed in our common adverse effect of NSAID. Naproxen, long-acting potent NSAIDs used in acute gout, ankylosing spondylitis, dental surgery or dental pain, and adverse effect, see the common adverse effect of NSAIDs. Diclofenac, most commonly used, indications rheumatoid arthritis and osteoarthritis, post-operative pain, dental surgery or dental pain, musculoskeletal pain, post-traumatic pain, dysmenorrhea, and for adverse effect it has already discussed in common adverse effect of NSAIDs. Ketorolac, mainly used as analgesic, post-operative pain, dental pain and acute musculoskeletal pain. Clinical use of common NSAIDs for analgesia, short term use aspirin and paracetamol, ibuprofen, and for chronic pain we can use naproxen. Post-operative pain we can use ketorolac and diclofenac, and for anti-inflammatory effect like rheumatoid arthritis or connective tissue disorder, gout, we can use naproxen or indomethacin. Antipyretic effects, paracetamol has antipyretic effect, antiplatelet function, aspirin has antiplatelet function, and for primary dysmenorrhea we can use mefenamic acid. Now come to the contraindications of NSAIDs, active bleeding peptic ulcer disease, number 2 chronic peptic ulcer disease, hepatic and renal disease, coagulation disorders like hemophilia, bronchial asthma, undiagnosed acute abdominal pain in influenza and swine flu. Now, come to the difference between opioid analgesics and NSAIDs. Mechanism of action: activation of opioid receptor, NSAID inhibition of prostaglandin synthesis, produces necrosis. Opioids that produces narcosis, but NSAIDs that don't produce narcosis. Opioid has a property of cardiorespiratory depressions, but NSAID has no tendency or no property of cardiorespiratory depressions. Opioid analgesics used opioid analgesic can do urinary retention, but NSAID do not cause that. Opioid analgesic has a role in constipation, or that can do constipation, but NSAID that don't cause constipation. Opioid analgesic tolerance present in opioid analgesics, but absent in NSAID. Dependence, that is present in opioid but absent in NSAID. Anti-inflammatory effect: opioid analgesic has anti-inflammatory effect, but NSAID lacks of opioid analgesic has no anti-inflammatory effect, but NSAID that has a property of anti-inflammatory effect. Antipyretic effect: opioid has no antipyretic effect, but NSAID has antipyretic effect. Precautions should take before prescribing NSAIDs: prevention of GIT irritations. A preventive anti-ulcerant therapy or proton pump inhibitor must be used. Number 2, caution in case of comorbid conditions, asthma, COPD, or any history of obstructive airway disease. We should take history of hepatic impairment. We should also take history of renal impairment and history of present active bleeding or any type of bleeding disorder that has to be noted. Any history of drug hypersensitivity reactions to NSAID, and at last, in case of female, pregnancy history is mandatory. There is a difference between ketorolac and mifepridine. There is a similar difference we have already discussed between opioid analgesic and NSAID, so we will not discuss it. Next slide. Commonly used antipyretics are paracetamol, diclofenac, and aspirin. These are the common antipyretic agent that is commonly used, but paracetamol is mostly prescribed. Selective COX-2 inhibitor characteristics: is more selective action, few GIT adverse effect, suitable for patient with peptic ulcer disease and bronchial asthma. They have increased chance of renal injury and CVS toxicity. This is all about today, and thank you all for patient hearing. Allah Hafiz.